I do. I mean, I have no compunction to substitute decitabine or cedazuridine, decitabine, or Aztec 727 at all now in patients with MDS. Now, through the years, I've put on many patients on study, and I've got a sense of just like many of us have who have treated people with parenteral DNMTIs, of kind of what to expect and how closely to follow them. And, just like the oncology community went through an adjustment when capecitabine became available, people do have to take this seriously. This is not a vitamin. They go home with chemotherapy, and they have to be watched appropriately. But oncologists who give us capecitabine can also very quickly become comfortable with this paradigm. So I actually have no problem with that. What I do have a problem with is extrapolation into combination studies, extrapolation into use in different patient populations. For example, relapsed refractory AML. It's maybe less of appropriate there, but more of a concern is with all these new drug approvals, it's hard to keep straight. And there's an oral azacitidine, which does not have cedazuridine bound to it, or any other cytidine deaminase inhibitor. So it doesn't really inhibit cytidine deaminase, and large doses are given in order to try to overwhelm this and get into circulation. But what's in the circulation provides a vastly different biologic effect. It doesn't mean that oral azacitidine or CC46 doesn't work, because in fact it does have activity for sure, but it probably has different activity, and that drug should not be used at all in patients with MDS. It should only be used per its label in patients who have acute leukemia, were well enough to get chemo, but not well enough to continue with consolidation after a cycle or so. Maintenance therapy with oral AZA or CC46 worked well. It's important that we distinguish how to use those drugs in the MDS setting.